box. And we want to thank you all for being here today. So Dr. Michelle Evans is a licensed clinical social worker, certified alcohol and drug counselor, and licensed sex offender treatment provider with experience in individual and family counseling and in developing therapeutic groups. We welcome her today and thank you very much for being one of our presenters. We can go to the next slide. So this presentation is in collaboration with Region 4. You can visit their website, it's there on the screen. Also, I want to let you know that you have this slide in the handout box, so you can download the presentation. And the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. And this is our signs that we usually have in all our presentations. So please, if like the citation of the source is appreciated, do not reproduce or distribute this presentation for a fee without specific writing authorization from the MHTTC network coordinating office. This recorder will be available also on our YouTube channel. Also, if you have a few minutes, you can follow us through our social media network. It's at HILA, H-I-L-A. And also, we can go to the next slide. There is no disclosed conflict of interest during this presentation. And also, we want to welcome Dr. Michelle Evans. I hope you can enjoy this presentation.
All right, wonderful. Well, you can hear me, hopefully, and now you can see, you can see what we're doing here. So let's get all settled in. Well, I think good morning for some of you, good afternoon to others. I know many of us are all over the country right now, which is just remarkable to just reflect upon just how there are so many of us doing this work. On a regular basis, we are working to best help our clients. And, just the fact that you are here, really encourages me that there are individuals, that there are treatment providers and others out there that are really working to ensure that our clients are have the cultural accommodations and adaptations that they need. And so I'm just so happy that you're here and interested in this work. So for some of you, this might be one in a number of different webinars that you've attended with the MHTTCs. For others of you, this might be your first one. And so I'd like to say just a little bit about the mental health technology transfer centers in my experience. I became aware of them a couple years ago as a clinician, and started to really look at many of the products that they were providing and just the access that they were giving. And it's free. I know they've worked with my facility, which I'll tell you a little bit about, and I've just been really happy to just see our ability to focus on this really important topic, which is cultural competence and cultural adaptation. So to give you a little bit more about who I am and what I do. So I'm Dr. Michelle Evans. As it was said, I have experience working with this population. I'm a hospital administrator for a psychiatric hospital, and I'm also a clinician, primarily working with individuals with addictions, sexual addictions, chemical dependency addictions, and severe mental health issues. So I have about 20 years experience working in this world as a social worker, specifically, both as clinician and an administrator. And so as I speak to you today, I'm coming from that perspective of just looking at what our agencies are doing on a larger, from a larger perspective, but also what we're doing as clinicians. And I know many of you are involved in all of this work on a micro, meso, and macro level. And it really, when we're talking about cultural competence, it really takes all three of those levels, especially as we look at the world that we live in, which is we're increasingly aware of just how systemic racism is impacting our facilities. And so this certainly is not a presentation on systemic racism. However, I do like to, I'm going to open up today in just remembering that our agencies and our work is being done within a world that is systemically racist. And so as we think about cultural competence, and as we approach this topic and we approach even our own engagement with it, we have to start thinking about our own biases and our own norms, and the things that we do every single day. And as I look at adapting our work, this is such an opportunity for us to start to change the conversation from this is just what our hospital does or what our agency does, to this is what the patient needs. This is what the client needs. And so as we're talking, that's really the kind of perspective that I'm going to work with this. So first of all, I'll talk a little bit about our objective. So you know, whenever we are starting out on something, if you don't know where you're going, then any path will get you there. But with this, we do know where we're going. So our learning objectives today. So this module will provide training on the integration of culturally centered interventions in mental health treatment. So some of our objectives are to apply culturally centered interventions when working with Hispanic and Latino individuals, discuss 8 areas of culturally centered interventions, and you'll be able to identify specific elements of the Hispanic and Latino population which may need special attention, and demonstrate the use of 8 culturally centered intervention modifications. And so as I start here, I know, so my own dissertation, a while ago, I did a doctorate actually in social work, and I was looking at ethnocultural empathy. In my work, I did a national sample through the NASW and looked at how valuable cultural competence was, specifically cultural competence training, when it came to the social workers' ability to better empathize and understand how to use cultural competence in their work. Unfortunately, and this goes against everything that I'm doing here, it turned out CEUs really didn't help. I shouldn't be saying that with this, should I? What it did find was that what was really helpful was the individual's actual experiences. It could be their own personal experience of understanding and prejudice, discrimination, cultural difference, or their experience in working with those populations and being able to see and feel just the struggles, you know, and the difference that either cultural difference, you know, oppression, prejudice, and stigma cause those populations. And so I'm very aware in starting this, I am very, very aware, and it's my intention that this isn't just a, let me give you some information and okay, that's great. We did something great today. Let's stamp our calendars that we learned something. The real goal here is to be able to look at our work, look at the things you do, look at the populations you work with, and start to approach an understanding of how culture impacts individuals. And whenever we start, we always start with ourselves. You know, culture is something that it's kind of like skin. You don't feel it until it rubs up against someone else's, you know? And so with culture, often when I ask people, tell me about your culture, there's kind of a pause because it's like, well, I'm just me. Everyone else is culturally different than me. I'm me, and you know, people are culturally different. And so to take a step back today, as we're thinking about even your own experience of being an individual with culture, with a culture, I'd like you to start there in your thinking process, because especially as we're talking about these 8 different areas where we can adapt cultural centered treatment, you'll be able to start to see and start to understand what they are for you, which will better help you understand what they may be for our clients. You know, especially in adapting treatment, when our clients approach us, they walk into the office, and we're, you know, we're coming together with them to start to work with them. their ability to see that we are accepting, their ability to see that we understand, that we're willing to meet them where they are, is just as significant as our understanding of what they're presenting with, you know. And so that culture piece and that cultural adaptation, it really requires that we understand what about us impacts our client's perception of the work we do, as well as it impacts our ability to actually change and adapt the treatment that we're doing. So, all right, so we have a goal here. Here's where we're going. So let's get started. All right. So first of all, we'd like to start with the beliefs about the origin of illness. If you attended our seminar last week, you'll have heard our discussion just about about how people understand where illness comes from. And
Michelle,
so,
I'm so sorry to interrupt you. And Marie's gonna do the poll questions, so we can start with that before you start with the materials.
Perfect.
I apologize, sorry. Thank you.
All right, here we go.
Okay, let's do the first one. And it reads, personalistic concepts of illness imply that recovery entails the use of rituals and symbolism. Please select one of the following, true or false. We have a 70% answering true and 30% answering false. Let's do the second one. Research shows that culturally adapted interventions have similar dropout rates than non-adapted ones. Please select your answer true or false. For this one, we have 16% true and 84% false. And the last one, in culturally centered interventions, persons refers to the individuals the client expects to be involved in the process. True or false? We have 89% true and 11% false. There you go, Michelle. Thank you so much.
All right, there we go. So I appreciate that. I'm glad we were able to get that working. And so because it gave me a lot of information just as to where you are, just even in your knowledge. And so I think it's really great that we can have this discussion. All right, and so here we go. So moving forward. So beliefs about the origin of illness. So our own belief about where does illness come from is really, it is something that comes, you know, through our upbringing. Think about, I know we're coming into the colder season, and you would go outside without a hat or a coat, and what would your mother say? You're going to catch a cold, right? This is part of just our understanding of where does illness even come from. Because again, if our mother's telling us, hey, put your hat on, put your coat on, you're going to catch a cold if you go outside like that. Well, that also inherently prescribes what are we going to do about it when we get that cold, you know. And so you get a cold, what do? You bundle up, you put the blankets on, you know, you eat hot soup, which is, you know, which it's all connected. And so when clients approach us for treatment, understanding what they believe about where their illness comes from is extremely important. And like I mentioned, there was a module last week that we discussed where we discussed much of this. And so I'm going to go through it just a little bit more, you know, just add a little more to that. So there's three primary belief systems of the origin of illness: personalistic, naturalistic, and biomedical. And so as we look at a personalistic system of belief, the individual may believe their illness was caused by the intervention of a divine being with special powers. It may be caused by retaliation for sins or disrespect to an ancestor, may be believed to be caused by bad luck or karma, and its recovery entails the use of ritual and symbolism, often by natural or spiritual healers. Now, this is something that, there can be, formal beliefs within a culture, but also often there are beliefs that that might be very individual, depending on how you grew up, what your parents talked about in terms of illness. I'm thinking about our current illness going around, which is COVID, and thinking about how, someone gets sick, and it's instantly, what do people say? Oh, I knew they weren't wearing a mask, or, oh, you know what, they weren't following guidelines, things like that. And so instantly it's attributed to something bad, almost, something that's, this is karma coming back because they weren't following the specific guidelines. It was bound to get them. But we often hear other things, said about why different people now, and we know that it's, well, and I guess this shows my bias in terms of here, we believe that it is a virus that is passed, from person to person. But even so, there are other ways that we discuss it. And in that way of discussing it, we can hear our beliefs about the origin of illness. It isn't just, well, they caught a germ. Often there's much more than that when we're actually discussing how someone got something. Think about, individuals that you've known that that may have gotten cancer or may have gotten other types of illness, even mental illness. And where does that individual or their family believe that it came from? One resource that I refer to often within my discussions here, within these webinars, is the cultural formulation interview, which is at the back of your DSM-5. The reason I refer to that a lot is because it really talks about how to assess an individual in a culturally appropriate way. So if you haven't looked at it, I highly recommend taking a look, even if you are not looking for a formal assessment of any type. The questions in the back are written in a beautiful way that really helps us discover some of these things, and there's another discussion, another webinar that we do that goes through the different, CFI points, point by point. But even in asking, well, why do you believe you have this illness? What do other people in your family believe about, why you have this illness or the causes of this illness? Those sort of questions really help us to identify why this individual believes that they may have gotten, the illness that they have, whether it's mental health or other illness. There's also naturalistic. And so the naturalistic belief of why we have illness is because harmony and balance is sought in maintaining health and well-being. When there's not balance, illness results. So naturalistic treatments increase metabolic health through diet, exercise, and energy balancing treatments. And so I know we hear this talked about a lot as well. As we're talking about individuals who, who talk about, what, I just haven't felt right lately. I've just kind of, there's just something that as, just burning the candle at both ends is commonly used as a phrase in really discussing this point of the whole, I'm not well balanced, I'm doing too much work, or I'm, doing too much of whatever it might be that's stressing me out, And so in common discussion, we often have just ways that we refer to this. And what do? Often many of our illnesses, okay, I'm going to eat some vitamins. I don't know how many of you are working to maintain health by taking in more vitamins, being attentive to your sleep patterns, being attentive to exercise to make sure that you can maintain a good and healthy balance to stay well. And so that's part of this belief. So I hope also, as you're hearing, that as individuals, we can have multiple, it's not just one or the other. Often our own culture shares many of these based on our own culture and how we've grown up. So with naturalistic interventions, some of those, we might look at the humoral approach, which focuses on attention to diet and activity, such as exercise. Ayurveda focuses on exercise, yoga, meditation, massage, just the wellness of that physical body. In vitalism, belief is the disease is the result of an imbalance in the vital energies. I know I have many clients that, that do a lot of what we call body work, which is the massage or, some of the other energy balancing activities that can be helpful. So, and thirdly, we have the biomedical approach. This is a system of beliefs that's summarized by the body as a machine metaphor. You know, what you put in is what you get out. Frequently used in Western medicine, and focuses on theory, knowledge, and empirical research of illness in order to advance treatment options. Yeah, and so I know, you know, I myself, I often discuss my own culture. You know, I grew up in a Mexican family, but at the same time, I am, you know, very American. I work within, you know, I'm in the northern part of the United States, and we have our very own culture. I know many of you are in the southern part of the United States, and so even that is part of my culture. And so as I look at this and I think about my own, you know, beliefs about where medicine comes from, I can see many of these, you know, even my phraseology about how I talk about illness, how I think about our current, you know, illness going around. I have many different beliefs about why it happens, and they're mixed. They're not always clear and compartmentalized. And so that's, I'd like you to suggest as your client is approaching your office to start engaging, first of all, is what is your belief? You know, where are you coming from as this is why depression happens? This is why anxiety happens or chemical dependency happens. And then because that kind of belief, it comes out in your language. It comes out in as you're approaching the problem and talking about, okay, we're going to create a treatment plan. And as you're discussing this, your bias, you know, of how illness even happens slowly kind of shows itself. And that's what your client's going to be seeing. And remember, your client may be completely aligned with you or may be very different. And in those conversations, as we talk about clients, you know, oh, this client was in compliance, or, you know, I hate that word. You know, but as we talk about our clients, you know, committing to treatment, you know, or aligning with our treatment recommendations, you know, this is our first step of, okay, are we in agreement just as to how the illness happens, and how can I as a provider, you know, withhold my own bias as to how illness happens, you know, to allow for them to share. You know, tell me more about how, you know, what you believe about illness, you know, and where it comes from. So that's really our first step. And I always like to note this cultural competence, it doesn't take more time. If you're like me, you know, 100%, I don't have time for more, you know, questions, more assessments, that sort of thing. All of this is it's underneath the discussions we're already having. And a lot of it has to do with us just sitting and reflecting about, okay, how do I come off to my client? Because I have these particular beliefs about illness. And it's just adjusting the questions, and actually it can probably save us a lot of time just in terms of miscommunications and helping our client get on board faster because they can see that we are open and aligned with where they are. You know, so just to kind of put that out there. All cultures have the combination of these beliefs which influences their practice. If I believe something causes something, obviously my treatment for it is going to align with that just naturally. Theories of health and illness help clients understand their experience of illness and is the foundation of the basis of their understanding of the need for change. I spend a lot of time working with my clients to explain about it. That's what we call psychoeducation, explain why mental illness occurs, why they may be experiencing this, to discover what they believe, you know, and the evidence I might have to share, you know, for consideration. And this helps them take charge of their own treatment so that they can move forward in helping, you know, identify what treatments might be most useful for them. Providers who are open and non-judgmental will be better able to help clients formulate usable plans for treatment, because ultimately that's the goal. When clients align and they agree with the treatment, they're more likely to follow through. All right, so culturally adapted interventions. So as we all know, we all have evidence-based treatment. You know, we're talking about cognitive behavioral therapy, for instance, you know, and there's multiple other evidence-based treatment. So let's start with those. You know, those exist, very nice treatments shown to work when we use them with fidelity. You know, in your agencies, I'm sure you have things that are recommended by your clinical teams of this is what we do. And so as we're thinking about culturally adapting them, this isn't about creating all new treatments. This is about taking what we have and changing some of the things that won't affect fidelity, won't affect the reliability of the treatment, but will make it actually more effective because it will help address that individual client's specific needs. And so it's almost another way to think of it is personalizing this intervention. All right, but it's not just taking different interventions that are lots of fun and okay, we're going to throw you this because they told me this is what Latinos like. No, it's not doing that. It's taking the interventions that we know work and then working to adapt them to be more effective. So meeting the client where they are requires an integration of the following concepts: the client's concept of health, what they believe about their health and how they maintain it; their concept of distress and suffering. What is distress? Why do people suffer? Why does that happen? The client and providers, this is where you come in, the client and provider's cultural values, and then the diagnosis and assessment of provider. When we look at what creates best practice, so best clinical practice is evidence-based practice plus providers' clinical experience. Many of us have lots of clinical experience, plus the specific needs, especially cultural values and cultural needs of the patient. Those are the three things that we need to do best practice 100% of the time. So when we're looking at that in a cultural way, thinking about culturally adapted interventions, this is how we put it together. This is how it plays out. All right. So as we're going through here, as I mentioned way back at the beginning, our real focus today is thinking about your own cultural values and in whatever population you're working with. And of course, this particular webinar is geared for working with individuals who are Latinx, but you might be working with any individual of any culture, and these concepts I'm going to share with you still apply. All right. So here we go. The ecological validity model is a model that's created in order to provide a holistic framework to provide treatment. Research shows that culturally adapted interventions have lowered rates of premature dropout. And so this is a model that you can use. We love application. So this is a model that you can use and apply with every single individual that you're working with. I got to tell you, I have appreciated this because especially in understanding my own culture, it's helped me look and go, that's what my culture is, because it's inside of me. I don't necessarily see it all the time. I'm sure everyone else is, but I'm not. So this has really helped me identify what my culture is, but also so that I can identify the culture of my clients and I can adapt and I can bend with that. All right, culture-centered treatment, let's define that for a second, is used to encourage this cultural lens as a central focus of professional behavior. So in culture-centered practices, all individuals, including the treatment provider, are influenced by different contexts, including the historical, ecological, socio-political, and disciplinary. Okay, so that's like a huge mouthful there. It's one little itsy bitsy sentence that it says so much here. And so what we're looking at, both me as a treatment provider and my client, we're influenced by a pandemic. We are influenced by the history that we all live. If you're currently in the United States, there's a ton of history regarding race and ethnicity and mental illness and stigma and addiction and all the things we work. All of that history comes into the room with us when we are working with our client, whether we acknowledge it or not. The ecological, what's going on, what's going on in our world right now, our resources, even the weather, how things are affecting us, the socio-political, we're coming up to that really quick here. What's, socially, financially, what's affecting us and our communities. And disciplinary, when I look at disciplinary, I'm thinking power, the power structures within our world and within our agencies. In other words, our clients approaching us and going, I'd like some treatment, and we're making a recommendation, and there's always behind it what are the consequences if I don't agree? What are the consequences if I don't go along with that? And those are still within that context. Am I respected as an equal in this treatment intervention? Or am I just expected to, take what's recommended? And so in all of these cultural centered practices, depending on our particular culture, changes what we're expecting, and so every single person walking in is a fresh new person. I like to say that every single interaction we have with anybody is a cross-cultural intervention, because even if I sat down with you, even if you're from Northern US like I am, even if you have the same, same race, ethnicity, same kind of history, grew up in my neighborhood, we are still from different families. Oh, even when I talk to my own sister, actually, you know, even if you're from the same family, we have different experiences. We have different things that we have taken in to understand that we've started to adapt to our own experience. And so, and those things influence our culture, you know, and how, and especially when we're looking at treatment, how we prefer to participate in treatment. So the best approach to working within a culture-centered context, knowledge about specific cultures, and a not knowing stance that incorporates the cultural and the personal. And so I know way back, if we go, you know, so I started even talking about culture, I think we're at like 15, 20 years ago now. And way back then, you know, let's go back to the 90s. The, you know, kind of push within many of our professions was the, okay, let's everybody learn a little about every culture that you're working with. So if your primary population is the Latinx population, you know, so let's go, you know, we're going to talk to some people, we're going to get a book, learn, you know, eat some tacos, and there we go, know a little bit about that culture, and now you're prepared to serve that population. That information is good, it does help us. However, it's not everything that we need to do. You know, as you know, I've worked with cultures, of course, different than my own, and I can know their behaviors. I can know, you know, some of the common things that they do, ways that they celebrate holidays, but that still doesn't give me 100% of what I need to know to be able to work with them. That comes from that not knowing stance of, you know what, I know a little bit about your culture, but that's about it, you know. So in our willingness to learn and understand that every single person within that culture is very different, you know. And so even though we have an informed background about the culture, with this particular person that is currently sitting in front of me, I have a not knowing stance. I don't know if they do those things that are common within the culture, you know. Especially, I'm a person that my family, my family immigrated to the United States, but you know, then over time we've adapted different parts of different cultures, both here from the American culture, the Mexican culture, you know, and other cultures that have since married into my family and contributed. And so therefore, if someone's working with me and they say, hey, you're from Northern US, this must be your culture, or you're, you know, this is your family, it's not going to work that way, you know, because I've taken a little bit from many of the cultures that I've participated in. And then you add my culture of education, my professional culture, you know, the cultures that I spend time in based on where I've lived. And all of a sudden we see that there's much more to me than just my personal, what I was born. So that creates the ability to see the specific individual or family norms which impact the individual, which may or may not be congruent with the personality, especially regarding color, class, ethnicity, and gender, while simultaneously recognizing and respecting culture-specific differences that exist due to color, class, ethnicity, and gender, as I mentioned there earlier. So, all right, now we get into the good stuff. You ready? Here we go. This is the ecological validity model. And so in a minute here, I'm going to go through all these, so I'll let you read them right here. These are 8 areas in which you can adapt treatment to be more effective with ethnically diverse clients. And I got to tell you, you can be more effective, let's just cross that out, with clients, because every single one of us, even if we seemingly are from the same area, are a little bit different regarding what we like with this. So, all right, now I'm going to go through these one by one and give you very specific things, specific ways that you can apply these. So here we go. All right, first of all, this is the easy one. I like to start easy. You do the same thing with clients. Let's give them a good goal, you know, an achievable one, understandable one, so we all feel good. All right, here we go. Gets a little harder after this. I save the hard ones for later. All right, here we go. So language, define it. The actual language, right now I'm speaking English, but also includes local colloquialisms, I love that word, and idioms that impact the expression and understanding of what's occurring. I've gotten super attentive to idioms because especially if you have to translate, oh, they're a bear to translate. But they mean so much and they tell us so much about how we see things, you know, and so as we look at our actual language, I know, so I frequently do groups with adolescents. So like I said, I work in my outpatient work primarily with males that have sexual addictions and also chemical addictions. I have a group with adolescents. How I speak to my adolescents, and no, I don't do the whole, hey, yo, you know, no, I try not to do that. However, there's certain language that they use the newest one that they gave me, and so I'll give this to you. I have a guy, so we were talking, the question at the table was what is your goal for group today? And so one of my kids, we're all in the Zoom group, and he's like, yeah, today I'm just vibing. I'm like, vibing? What does that mean? I'm imagining like he's vibrating, which is not vibing apparently. And you're like, I'm just chilling. I'm just hanging out here. That's my goal in group, is just to kind of sit back and just kind of be here. New word. That is part of his particular culture, even though he has his own racial culture, ethnic culture, where his family is. But in looking at that, it's like, okay, what does vibing mean to him? How is that actually done? Because that particular word has been very, very impactful actually in his treatment. As he and I talk about what he wants, what his ultimate goal is. His ultimate goal is to vibe, if you ask him. And so he and I tell him, I'm like, well, I don't use that word. So tell me more about it. I want to understand that, because that word he uses to kind of exemplify having a nice life, being carefree, not having to worry too much about things, not having the problems that he has, not getting bothered by his parents. And so when he uses the word, yeah, my goal is just to vibe, I could, initially just interpret it as, yeah, my goal is like not to do anything and just kind of laze about group today, if I put my, adult hat on and, my responsible adult hat. But when I hear it from his perspective, and how he uses it as an adolescent, it's very much, I want to live a carefree life where I really don't have a lot of problems. It's where he's coming from, So I don't know if you've heard that word, but there you go. I've given you a new word today. But that is a word that is specifically for him and his generation, and all the other kids in the group know what he means. I'm the only one kind of on the outside here, again, looking at that cultural difference, and in this case, it's based on age, and going, okay, he could certainly change his language for me so I can understand. If I don't know what that means, use a different word. I could force that on him. However, it would rupture our relationship. So instead, learning what he means by it, it provides us this common word that we can even evaluate. All right, how's the vibe been this week? Tell me about what's going on, because that is a very meaningful word for him there. So it provides us the communication tool for the speaker to communicate concepts which are valued by that culture, such as in this case. Individuals are not likely to think of ideas which they cannot express within their culture. Knowledge of the language usually implies a greater cultural knowledge. And so I like that second point. Remember, every single culture has a different way of expressing certain things. I know I often do treatment in Spanish, and the word I always struggle with is they don't have the word trigger. And so we can say, things that cause things, we can frame it in a different way, and maybe if one of you have a good word for trigger, I'd love to hear it. All we have is the one for gun. So sometimes I use that for fun, just to kind of explain it. But and there's other words that are used, but in English, we love that word trigger. We use it, oh, I'm getting so triggered, by that. And it means something very, very specific. And so as we work with clients who may not use the language as we use it, in English we use the word trigger, they might not use it that way. We have to think, what this word means to them, especially if they are translating it into their own language. And so the importance to Hispanic clients that can express themselves better in their native language, of course. Local dichos or idioms can connect cultural metaphors with the client's experience to increase their understanding of treatment concepts. Language might also indicate an acculturation or assimilation levels, especially in their understanding. I've worked with many families, and especially when I do family therapy, and I have parents who, prefer Spanish, do not communicate well in English, and I have an adolescent who speaks English and does not communicate, emotional words well in Spanish. It's always a very interesting session. And that is really telling to me as a treatment provider of just the connection that the family has and how they're communicating to each other, as we go forward. So what can you do? All right, here's the application part. So first of all, appropriate translation and interpretation of communicated information. Okay, so here's like a little pet peeve that I have. Translation, written documentation. You translate written words. Interpretation is the verbal. you know. So and sometimes I switch it too, but there's two different things. And so often with translation, we need to be able to get those documents that we can share, you know, especially documents that the individual is relying on to understand their responsibilities in treatment, you know, and having the appropriate people interpret it. The gold standard for interpretation is double blind, you know, where somebody translates it, let's say, from English to Spanish, and then another person translates it from Spanish to English, and then we can compare the two to make sure that it's an accurate translation, which is so important, just so our clients can know what's expected and what they're agreeing to. And that's a level of respect as well. It really shows our desire to have them, you know, as an equal partner. The provider should clarify any language embedded meanings that are conveyed through sayings or metaphor. Again, that's why my ear is always listening for the idioms. You know, I think I used earlier, burning the candle at both ends. You know, imagine if you said that to someone that didn't speak English, you know, and didn't know the colloquialism. Be like, what kind of candle has wicks at two ends? That's a really dumb candle. How do you even put it down? You know, and so we have to watch that, because sometimes we can, in expressing, you know, treatment terms and goals, we can confuse, you know, the topic here. And then many theories encourage the naming of experiences of distress and suffering in order to reframe and retell these experiences, you know. And so with this, as we're talking about adapting treatment. And so as you're using one of the evidence-based practices and you're looking at what they call things, remember I mentioned trigger, you know, in CBT, we love the word trigger. As you're looking to adapt that treatment to be usable for your client, you're paying attention to the language used and making sure it's aligned with how your client speaks and how your client thinks of the world, especially regarding to distress and suffering, you know, to help them to reframe, retell those experiences in language that's meaningful for them. All right, so I told you that was the easy one. Let me give you another one. All right, persons. This one's a good one too. I think I'm going to say that for all 8 probably. So persons, definition is, this concept refers to the individuals that the client expects to be involved in their treatment and the significance of each of these persons. It can mean the significance of the individuals involved in the client's care, including family members, holistic healers, extended family. Refers to the client-provider relationship during the intervention. So when I work with, especially my Spanish-speaking clients, our relationship is typically, because this is always typical depending on the individual, but typically very professional. I give my clients the option, they can call me Michelle, they can call me Dr. Evans, depending on what makes them feel most comfortable. I want them to be able to share. And I've had clients say, you know what, I can share with Michelle, you know, but Dr. Evans, that's like, I'm supposed to, you know, it's just way too high and mighty. Perfectly fine. Others are like, no, I came here for a professional, you know, for your professional expertise. Dr. Evans can give that to me. Great. You know, and so as we're looking at working with with individuals, being able to assess our relationship and what they expect of our relationship. Again, I work in the addictions field. A lot of times I work with forensic populations as well. And often our relationship's a little more irreverent. You know, if people are coming from prison, people are working through addictions, that's a whole different kind of way of working. And so being able to work with that and then transitioning to work with, let's say, I'm working with a Latinx family, you know, that they're coming in for, you know, issues with some of the younger kids. Very, very different. They expect different relationships with me, and I have to adapt, you know, me expecting them to adapt because, hey, that's just the way I am, is not culturally appropriate. You know, it's not going to get me the farthest that I can get. And so the importance to our Hispanic clients is clients may place a high value on personalismo or friendliness. They may be more likely to place a high level of trust in one professional instead of relying on multiple specialists. The client might not always express disagreement to individuals that are in positions of authority, but then might not follow treatment recommendations. And so the understanding is that this is a professional highly trusted, but also it's not polite, you know, if this person is an expert, it's not polite to question them, not polite to say, you know what, I think you're wrong, which I'm in the northern US. Our culture is, if you don't think the doctor's right, you tell them, and you bring in your WebMD, you know, so what I got from the internet, what do you got to say about this, doc? You know, this is different than what you're saying. Northern US, we do that. It's, you know, often with this, you know, with this population, that's not what's going to happen. You know, and so as a clinician, it's understanding that. and looking, and so I'm always looking and reading the nonverbals of, all right, is my client committed to this process? What is telling me that my client's, saying yes, but due to the respect and them not wanting to question me, they're not aligned with it, and sometimes I can see that there's non-compliance. They come back the next week, hey, why didn't you do this? We said last week you were going to do this. What happened? And sometimes that's where I see okay, you weren't on board in the first place, but you didn't tell me, and even discussing what their expectations of me are and how they can politely express if they, if they like something, they don't like something, and open up that discussion. Also, of course, the personalismo, I have individuals that call me from years back, even though I don't see them anymore, but I know people, and so they're like, hey, what is your advice here? What do you recommend with this? And I know with many of my clients, understanding my background is helpful for them, because then they understand, it's like, this is who you are, and so, and what my family might be like, how my mother is, and so, and that can be very helpful. And so some of the specific modifications, application point, specific modifications for the Hispanic and Latino culture are: the provider needs to focus on developing rapport with the client. So like I said, that relationship part is super important. And I got to tell you, so research shows that no matter what, obviously we all use evidence-based practices. Those are great. At the end of the day, though, if you have an evidence-based practice and you don't have a relationship, you're not going to go as far as if you had that relationship. Relationship is the most important piece of treatment for change. So that's a little Easter egg there. The treatment may include multiple members of the patient-defined family. I know when I first started out, I was terrified of family sessions. Had to get over it, because you know what? That's an important cultural point. Treatment should empower clients with the provider as the guide. We're guiding them, but they have the power, of where we're going to go with this. And we have to remain mindful of the referent power that we have. Referent power, so if you go look, and this is actually a business model, there are, I think it's 7 different types of power. We have coercion, expert, informational, knowledge power. In those powers, though, we have reverent power. And reverent power means relationship. It means that I have power because I'm likable. My client likes me. And so when I go, hey, you know what, I really think you should try this, they go, okay. It's that idea of that personalismo, of the, hey, we have a relationship, we have this thing. And so when I say, this is what I think you should do, they're more likely to go along with it, even if they might have reservations or it doesn't align with some of the things that they believe, and so that's an important thing to just be aware of, is that reverent power that we have, that we build. So, all right. So now we get into the slightly more technical. So metaphors. So the definition of metaphor is no different than the usual definition. This concept refers to symbols and concepts shared by a particular group. It helps individuals make meanings of new situations based on previous experiences that they've had. It may connect seemingly unrelated situations together due to the similar meanings experienced by the client. So if we go back to high school English, you remember what's the difference between a metaphor and a simile? Simile is like an as, metaphor, it is. And so when we're working with some of our clients and we're thinking that, and we're talking about different things, sometimes situations of power. We're thinking about, especially if we're working with our immigrant populations that may have lived with powerful governments and have left that, we're unheard. We're not given the ability to speak out. And now we're in a situation where maybe they're working with the school district, maybe they're working in school and not getting what they need. And so, we have 2 situations here where they're dealing with larger bodies of unknown faces. And those 2 situations can trigger some of those, just feeling of power or powerlessness. And, and they can seem very similar. Yeah, sorry, I was hearing something. And so we have to be mindful of that, especially as our clients are coming in and even talking about treatment. We're coming in and we're making recommendations. And the question is where else have they experienced this? where else have they experienced, working with a treatment provider like ourselves, having this relationship? Because often possible bad experiences in the past of working with treatment providers, doctors, people that are recommending things for their family, if they haven't gone well, they can take that same experience and adapt it into ours, which, it makes it more difficult to be able to build that relationship. However, additionally, we have the opportunity, thinking about metaphors, we have the opportunity to change things for the better as well. So when individuals have positive experience with us, they can go forward and learn that, in my case, social workers are good people. I once had a client who, now I'm a social worker by trade, and the client came in and just was a crab. And so we're talking and he's like, well, I hate psychologists. I'm not working, he's like, I've been to psychologists before and I love psychologists, by the way. So for you psychologists out there, this has nothing to do with that. This is just a story. And so as he was talking to me, and I'm like, oh, I'm a social worker. And instantly his entire expression changed. He's like, oh, I love social workers. He's like, my social worker is so helpful at the school. He's helped my daughter, get these things, and the social workers helped, get the things we need. Oh, that's great. And so I'm thinking there, because literally, all of my fellow clinicians at my outpatient office are psychologists, are wonderful people. But this individual, this was his experience. He had this metaphor of what a psychologist is and what a social worker was. And even though I'm in the position as a therapist, I could have been either. He's adapting that and instantly just saying, this is where you are. This is who you are. And so being able to flesh that out and going, oh, no, let's talk about your previous treatment experiences. What did go poorly and why, why was that? Was helpful. So the importance to Hispanic clients, like I mentioned before, individuals of power may symbolize oppression or prejudice to the client, which may impact therapeutic rapport. Provider that's less attentive to these variables will be able to identify the positive symbols that are helpful for the individual and minimize symbols that are negatively impacting the treatment. The question I like to ask is, what does this mean for my client? I just asked my client to attend a group. What does that mean for my client? So some modifications that we can make: treatment needs to explore the patient's story as understood by the patient, including the patient's perception of his or her experience. Provider must remain mindful of the differences in personal involvement. Again, that meaning of the provider and client as an individual or family goes through changes. And so this is that, just looking for what is the meaning. When I say, you know what, you need treatment, what does that mean? Does that mean help is available? Or does that mean I think you're sick? Those are two different meanings, and based on the metaphor of their understanding of illness and treatment, we can be conveying two different things with the exact same language there. All right, next one up, content. So it refers to the cultural knowledge about values, customs, and traditions. Each client may be influenced by cultural values, customs, and traditions specific to their family, community, and race. So you remember a little while ago, as I was talking about culture-centered treatment, I said that knowledge, general knowledge of the population, and what they do is important. This is where it comes into content here. So the importance to Hispanic clients is that clients may have unique values, customs, and traditions that connect them to their native countries and to their families. Being conscious of the impact of cultural content can allow the provider to hear the specific problems and concerns that their clients have in order to address them efficiently. Understanding holidays, understanding behaviors, traditions, foods that are eaten, and also listening for them in terms of when the client is expressing, hey, this is what I enjoy doing. This is what we're doing for the holiday. We have all of our holidays coming up here soon, and being mindful of, okay, here are some of the content, things they might talk about, can help the client feel that you're interested and you care, and search out information. Obviously, one of the best cultural practices is not to have your client educate you. That's not your client's responsibility, but to seek out individuals within that community, participate in events in that community, and to seek out to learn about that community. Again, I like to highlight that it's never our client's responsibility to educate us about their culture, to give us this content, but it is our responsibility when we're working with a population to go out and learn about that culture, whether it is in being involved, finding an expert, a colleague that knows and that can inform us so that we can develop this content knowledge to be able to connect with our client and show some understanding. So some modifications for the Hispanic and Latino culture. Our treatment needs to be holistic and may need to incorporate spiritual or other elements from the patient's culture. Having the content, being able to hear that, oh, this is a culture specific behavior or activity that they're participating in, can let us know what we need to incorporate. Understanding how holidays work, specific holidays that whatever culture it is, how they celebrate it, can especially inform us whether there may be issues of relapse, risk, being triggered, all those things that we normally look at in treatment. Understanding the content and what happens during holiday events, for instance, or other interactions can be very helpful to us. Treatment may incorporate values, customs, and traditions. It also increases the amount of comfort and familiarity that the clients have with therapy related to tasks. Now, I'll take a moment, so I mentioned way back at the beginning that I look at this in a macro, meso, and micro way. So, and I've been talking a lot about, the micro level. So for those of you that supervise, run agencies, I just like to put this little thing in because content, sometimes it's the easiest thing that our agency can do to change on a broad level. Especially when I walk through an agency, I'm looking at the walls, I'm looking at the website to see who is pictured. As I'm looking and I'm thinking about whatever population that they serve, I'm seeing, is that population reflected in the walls? Is that population reflected in the availability of language appropriate materials? Is that population reflected in the website? If I'm working with a primarily Spanish speaking population and my website's all in English, what does that say to my population? And so this is a primary way that on that macro level, in the meso level, that we can start to adapt in our agencies, in the community that we work within. All right, so next one up is concepts. So the definition is to refer to the constructs of the theoretical model that's to be used in treatment. So this is where, you remember what I said, best practices of treatment is evidence-based practice plus our clinical experience and the specific needs of the patient, adapting for the specific needs of the patient. And so this is where those concepts come in. As with any treatment, when we're using an evidence-based practice, we are choosing the practice based on the client's needs. And so as we choose the specific concepts that we're going to work with in this treatment intervention, we're thinking about the needs of the patient and we're thinking about the specific theory. And so therefore, choosing a theory that aligns with the way that the client thinks about the world. I love CBT. However, it doesn't work with everybody. Especially for individuals, CBT tends to be very, very, much into how do I think, what do I think about, and looking at those, core schemas. And if I have a client where that just doesn't align with how they think about their illness, no matter how much psychoeducation I give them, sometimes I have to move into a different theory that might be more amenable to how they see the world. I mean, let's how we choose the theories that we like to work with as a provider. I choose theories that make sense according to how I see the world. I understand, I love CBT because it makes sense. Theories, core beliefs that aren't helpful. Well, guess what? They ruin my thinking. This my frontal lobe here, where I think that's what they hurt me there. So, well, of course I'm going to try to change it. That's my thought as a provider. But if my client isn't understanding that or just doesn't believe it, well, then I shouldn't be choosing that as a theory. And so that's what this is talking about here, is those concepts of making sure we're choosing the theoretical model and using the constructs of that theoretical model that align with how the client sees illness and how they see the world. Concepts incorporate the provider's understanding of the client's problem and involves the client's understanding of that same problem. The provider's and client's understanding of the problem is not conveyed, there might not be an adequate partnership to complete treatment goals. I don't know if you've ever worked with a client that as you worked with them, you're like, I keep talking to them and it's like, the second I throw something at them, it just like falls to the ground and I sit there and look at it and feel very sad. That is because the therapy and the client just don't match, and so then you have to go back and reassess. The importance to Hispanic clients, theories should be used that allow for the integration of the individual's cultural values and beliefs so they can understand and accept the framework of their problem. the client's understanding of his illness is incongruent with the theory, he might not be able to fully participate in treatment. And so some modifications that we can have. So when choosing a theoretical framework to use, ensure that it's consistent with the cultural concepts of the individual that's being served. Again, I mentioned the CFI. There's a lot of concepts. It asks right there. It shows you how to ask the question, which is super meaningful and helpful. And I also use this just as a, when you are work with a client. So let's say you're going to go back, work with some clients, forget about cultural competence for a second. When you're working with a client and you're seeing that this just isn't working, you know, we're doing all the technically correct things in this treatment, but the client's not engaged. They're not, it just isn't a good match. I will promise you, I'd say 9 out of 10 times, it's because culturally it's not a good fit. I think cultural is that important because culture is how we see the world, the concepts, all this treatment. And so when it actually, when you know, culture just isn't working, or when the treatment's just not working, usually it's that culture thing that we're just not matching. There's something we don't understand about how the client is seeing us, the treatment, the illness, and we're not responding accurately to that particular thing. And sometimes it's so invisible. You know, again, it's like that skin where we're feeling, and we're like, oh, I just can't put my finger on why this treatment isn't working. And often it's stemmed, its core stem is in that, you know, we've just missed the boat on how the client sees this issue, and we just don't have a good match in terms of those concepts. All right, so here we go. Goals. We love goals. I love SMART goals, by the way. So definition, it refers to the identified outcome of treatment. What do we want to get from all this? We're going to spend time together. What do we want at the end? It should reflect the client's and provider's understanding of the problem and of the situation. It should be specific to the client's problem, attainable for the client by using his current supports and resources, relevant to the client's understanding of the problem, and offered at the right time based on the client's schedule needs. You know what? That sounds an awful lot like SMART goals, doesn't it? Look at it. It's in there. And it must be congruent with the client's cultural values. Yeah. It's a really weird floating family, by the way. It's an interesting picture. All right. The importance to Hispanic clients. If a client doesn't feel like a goal is worthwhile, his motivation for participation will be less. Due to respeto, which is like respect, Hispanic clients may be less likely to express disagreement with individuals who hold positional power. You know, like I mentioned, so here's that power. So that's a, you know, a little Easter egg, something to look at later is, you know, the different types of power. Highly recommend it. You know, I love using that in, you know, in other trainings, supervision trainings, etc. But with this, the client has to be on board regarding the goal. And so specific modifications that you can make. Treatment must incorporate values, customs, and traditions that are integrated into the client's understanding of the problem and continue the integration of these concepts through the goal-setting process. The approach will provide the client with an opportunity to integrate new goal behaviors and existing beliefs. So I told you earlier about my client that just wants to vibe. I personally would like him to do all sorts of other things, you know, because I'm thinking about thinking, I'm thinking about the anxiety he has, thinking about all these other things where I'm like, okay, goal here, goal there. And he just wants to live a carefree life. And so changing his goals so that they're not so hyped up, wrapped up in my therapeutic, you know, therapist words, and starting to help the client, you know, and help him see that, hey, we are working toward the same thing. You know, he's not very concerned about being able to identify coping skills. I know that's going to help him in the end. You know, but looking at it and being able to phrase it in the way and to show him, you know, or even, hey, here's your treatment plan. Ultimately, this is where it's going to get you so you can live that carefree life. You know, being able to connect that for him and making sure he understands that we're both going in the same direction, you know, is incredibly valuable with this. I know, so I've worked primarily with mandated populations for a long time as well. And I always say my number one, I don't want to call it a trick, but my number one method for working with mandated populations is to start with this. It's the whole, they come in and I'm like, well, what is your goal? And they're like, to get out of here. And I'm like, I 100% agree. You know, we are both on the same page. Why? You know, because, well, if you get better, you know, you appreciate, you improve the thing that you're working on, you know what, you'll be discharged. And usually I have never, it's actually never failed me, you know, because basically it's like, all right, you know, at least we're both on the same path to go. So that's what it works with mandated populations. Obviously with my voluntary clients, we work a little bit differently. So, all right. So next one is, I know there's 8 of them. Remember, there's 8. Almost there. Methods. So the definition of methods is methods are the procedures to follow in order to achieve therapeutic goals. That makes sense. So methods incorporate the theory used, but also incorporates the provision of the assessment, the use of transference, countertransference, the relationship, and use of specific interventions like group or individual treatment. As you may know, not all interventions, not all methods work for all people. And so often in our work with individuals, we have to think about, is this individual going to, you know, is this the right time, right method for that person? So the importance to Hispanic clients. In treatment, the experience, expression, and explanation of symptomatology is bound to the provider and client's intersubjective perspective, which is impacted by each person's culture. If the method to achieving the goal is not consistent with the client's understanding of his or her symptoms, the clients will not follow through with the recommendations. And so as we're seeing, you know, seeing through all of these, you know, 8 different things that we're looking at the individual, us understanding, okay, why do they believe illness happens? We're looking at, are we using the right concepts? In other words, the right treatment. Do we have the right goals? Are we all going in the same way? Are we using the right methods to get there? You know, and especially as we're working with the clients, it's understanding where they're coming from, you know, so that we can modify it, adapt it to align with their needs, preferences, and values. What, you know, and when I say values, another way that I describe values is what they prioritize. You know, if they value your family, it's telling me, okay, that's a priority over other things that you may not value as much. So specific modifications for the Hispanic and Latino culture. Hispanic and Latino clients may feel more comfortable participating in treatment methods that they're already accustomed to. So think about it, usually when people come in and I ask them, it's like, okay, have you ever attended counseling before? Yes, no. All right, what worked? When you were with that other therapist, you were in that other program, what really helped you? And what didn't? That tells me a lot about, you know, somebody else has already done the work to figure out what should I be focusing on, what might be most helpful. And if it didn't work, well, why? What went wrong? Was it that specific time in your life, or was there something specific about it that didn't match with what you need? The provider may encourage the client to express their culturally bound behaviors and feelings by way of methods that they're most comfortable with, or to resolve internal and external conflicts. Asking questions like, well, how do you talk about this at home? How does your family talk about this issue? Tells me a lot about what this particular issue means to that individual. And also, you know, if the client's telling me that, you know what, when my mom always talked to me about uncomfortable things, you know, we never look at each other. We talk, okay, that, you know, that particular behavior might be valuable here. Okay, well, how do you feel that we're both sitting across from each other, looking at each other? How does that feel for you? You know, it's something incredibly small, but, you know, when we think about it, it could completely change just how our clients feel. You know, I always really, for some reason, I'm kind of focused on what chair people pick in group. And if you start asking them, they always have very good answers, you know, and it's always related to their perceived relationship with me, you know. And so just a little thing you can play with there. So including trusted individuals and offering services in their preferred language can increase the client's comfort, of course, and that's a method, you know, of having family therapy, having couples therapy, you know, involving people that, you know, involving a friend. I've had clients bring friends, you know, to therapy so that we could gain accountability. And it was very, very effective, you know, because it wasn't just mom or dad. It was somebody that, hey, this is my friend. I've known him since I was 10 years old. I tell him everything. And he really needs to help me out here. You know, I have a problem. He's the guy that I'm probably going to talk to. All right, bring him in and we'll talk, you know. So now we're looking at context. So context considers the client's broader social, economic, and political circumstances. Whew. I am not going to do this one justice because there is so much going on here in the world today, you know. So we're going to talk about this very broadly. A whole nother webinar to talk just about context and its impact on the Latinx population today. The context of the intervention impacts the client's priorities in completing tasks if and how they follow treatment recommendations. So if you are working with populations currently and you are doing a lot of telehealth, yeah, priorities really have shifted. A lot of clients that I'm working with, and I know there are a lot of other webinars on working in telehealth, especially in today's world, you know, that we're seeing. And we're really, because context matters, and it changes, and it's constantly changing. So thinking about our context first as a, you know, what's going on in the world is important. But also, I like to look at context in terms of how we interpret this to be able to communicate. So I wanted to share this table with you. So in this table, we talk about communication and understanding based on high context cultures and low context cultures, all right? High context cultures put a lot of priority on just what is happening in the environment. And so when a message comes out, the culture is considering, where was it said? Who was in the room? I know something that, you know, so remember, you know, I've grown up in northern US, and in working with some populations, I had the bad habit. So this is, you know, this is a bad thing I'm going to share. I'm going to be vulnerable with you. So I had the bad habit of, when I walked into a room, just walking into the room, there might be different people. So remember, hospital, might be multiple people, you know, standing around, sitting around, multiple different cultures. And I'd walk in, you know, hey, I got to talk to you, blah, blah, blah. And because of my own hurry and my, you know, northern, you know, got to get things done, you know, efficiency, not thinking about culture, you know, and context. And I would inadvertently insult a whole lot of people, because in walking in, I wasn't acknowledging other people, or if I was, it was very brief, you know, and walking by. I wasn't asking them how they were doing. I wasn't pausing to have that interaction, to have that connection, which, especially in higher context cultures than my own, was super, super insulting. And so therefore I was going through and, you know, making enemies in some cases because of just something I was oblivious of, because I am a much, you know, this is a spectrum, you know, lower context, higher culture context. We're all kind of in somewhere in there. And as we look at my northern, you know, my northernness, very low context. Okay, we just come in, we get stuff done, and, you know, we focus on verbal communication, not a lot of body language, you know, versus I was working with populations that were much higher context, and they were noting my body language, the situation, who was talking to who and when, and thus I was communicating something that I wasn't intending to. And so I was able to correct that, and I've done a lot better. And so as we look, high context cultures look at what's happening. Who are we talking? Who's in the room? A lot of nonverbal communication. So again, I'm thinking about telehealth and how that's impacting us. You know, strong distinction between who's in and who's out. Strong sense of family, strong bonds, high commitment to long-term relationships, and time is open and flexible. Okay, so for my, you know, for my family, you know, and this is the higher context side of us, our reunions start at noon, everyone gets there at 3, you know, time, very, very flexible, whatever. Now, again, I have a very high context culture that I come from, but I live in a low context professional world. And so here we are, you know, especially hospital environment, what are we doing? Email is how we communicate, you know, and so as we look at low context, you know, we're talking about like northern US, definitely. If you're in the South, you're much higher context, certainly. You know, but US population in general is lower context than many of the other, especially Latinx populations. And so Asian populations, very high context. They're, you know, on the farthest end. German populations, one of the most low context culture. And so we're seeing much more focus on that verbal communication, flexible, or fragile bonds between people, little loyalty. It's okay, you know, much more business, low commitment to relationship, and the tasks are more important than the relationships. Remember me running in and running out of this, you know, this room. Time is organized, product's important than process. And again, all of us, depending on how we grew up, our racial culture, our professional culture, we're somewhere in there. And sometimes when we switch cultures, you know, you go home, you're one way, you're at work, you might be another way, there's other expectations. We change a little bit on this. All right, so the importance to Latinx populations impacts their understanding of the subliminal meanings that are communicated in everyday interactions. the provider doesn't understand the social, environmental, and economic situations, intervention might not be feasible. So remember me kind of making a fool of myself there. Some specific modifications for the Hispanic and Latino culture. Context is made up of the client's experience of acculturation, immigration, client stage of development, social supports, relationship with their culture of origin. We need to develop rapport with the client to create an accepting and supportive environment. You know, and again, especially if we're looking at this context, I'd like to include politics also matters. You know, the current civil unrest matters. All these things impact the context. Things that are going on now can affect what we can say. You know, it can affect how people hear them. All right, so we've gone through the 8 items here. I'm exhausted. All right, so now we're looking at application. So I'm going to offer this up to you just kind of as a demonstration of how to apply it. This is going to be rather brief. So you can, you know, and I'll put, you know, if you have some questions, I think we're going to have a couple of minutes here if you do have some questions, so you can start to think of that as I'm kind of reviewing this. So here's a case example. You've been assigned to develop and lead a mandated group of individuals that have been convicted of DUI. Population that will attend your group is primarily Mexican men, most who have immigrated to the US within the last 15 years. In the group, you found that significant number of men show depressive symptoms and have evidence of PTSD. The group is offered by a mental health treatment clinic in a large metropolitan area in the US. Your task is to identify culturally appropriate interventions for the group. All right. So as you're looking at situations like this, and I'm sure you have your own particular, you know, different things that, different cases, different groups that you have been involved in that where you need cultural adaptation. And so the first thing that you're looking at is how will you identify the cultural needs of the group? And so as you're talking to, so the men that you're looking at here, you know, it is a mandated group. However, there are multiple cultural needs. Most have been here for 15 years, but it is possible that you have some that have been there less amount of time, you know, as you're looking at them. You know, also you're looking at understanding of the use of alcohol. I know I work with chemical dependency, you know, understanding their understanding of alcohol. How is alcohol used? What's the importance of alcohol in their culture? You know, a lot of, you know, I've often worked with this population, and we're seeing the alcohol means something. You know, that's what, you know, how do you engage with your friends? How do you participate in family activities if that is something that's very, you know, that is used a lot in your friend group, in your family? You know, and so it's looking at some of those, looking at the content of the meaning of alcohol, the meaning of that experience, and then also looking at people. You know, first of all, what language, you know, what's the best language? How can the group express themselves? Also, do we need to involve other people? You know, we have a group here. How will they relate to each other? You know, are they, in terms of their particular stance, are they able to share openly, you know, with each other? Are there other people we need to bring in, family members, you know, maybe partners or others to help them with accountability? You know, thinking about personalismo, you know, how do I develop that rapport with each individual group member, and while also helping them to develop rapport with each other to make the most of that persons. So those are what I'm thinking, just in terms of language, persons, the content that we'll be discussing, the concepts, and especially some metaphors of what does it mean to be court involved, to be mandated to a group, you know, and is that fully understood? As I'm looking at measuring these adaptations, if they've been effective, I'm always looking at my clients. How are they? Are they finding the treatment helpful? Even if they're not necessarily, oh yes, I love this, I'm never going to drink again. It's do the things that we're doing, does the group make sense? Do the goals of the group make sense to them? You know, do they align with their lives, you know, what they're trying to achieve? I use, you know, just as a note, I use acceptance and commitment therapy a lot, which is heavily aligned with the individual's goals and what they want from life, you know, and so that's where I'm particularly come from. And so so I'm going to look if this group aligns with their values, just the content and what we're talking about. And then of course we have the wonderful, you know, Department of Transportation, you know, the curriculum we have to go through. But I'm also looking at those cultural needs. And as I said before, in terms of, I have a curriculum that I have to use, but I can also look at the people we involve. I can look at, the focus on specific things, even going through the content and pulling out questions to ask and to bring up that are going to be much more culturally relevant to my group than perhaps other questions, or even adapting and changing the questions a little bit to address what the individuals are looking at. All right, and so at this point, I don't know, do we have some questions that I can discuss or answer? Got a couple more minutes.
Thank you very much, Dr. Michelle Evans. That was an amazing presentation. Thank you for explaining all the context, goals that impacts how we deliver services to our Latinx population. So we have one question. It said, in terms of context, what are some of the challenges we can expect from working with Latino community and specifically with different generations?
So that's a wonderful question. And when I think about context, I remember that the different generations based on acculturation level will experience the context differently. And so as I'm thinking of even individuals that I've spoken to, as we look at civil unrest and we look at individuals that are a little bit older, they have a much different recording of what has happened in the past during previous episodes of civil unrest than perhaps our younger population, and what they know about it, their understanding of hearing about it or reading about it in textbooks, and also what they've been taught. And so I think it's important to, as we work with, families, to recognize that, unfortunately, even the context may mean something different to each member in the family. Half the time, that's why we have conflict, is arguing what's important and what's not. And so I think as we go through and especially work with families, or larger groups of people that are coming from different generations, we're looking at acculturation, we're looking at their understanding of history, we're looking at their understanding of the meaning of what is happening. And so I'm also thinking, parents, they're going to be much more stressed in terms of, providing for children. So we're thinking, providing for children, and so their priorities are going to be different in what's going on than, let's say, a child who doesn't care about if this costs money or not. They're just wondering why they can't go out with friends. And so those are some of the things that we're balancing. And so whatever kind of treatment we're providing, some of our goals just as treatment providers is to help that communication, and help that for problem solving, helping our clients problem solve, to help them gain that meaningful life or to resolve their goals that they're looking at. But yes, it can be, context can certainly, mean many different things. I mean, and lastly, I'm thinking about, as I talked about, kind of the ambient context, but as we're looking at communication, as I mentioned, in my own example, I have different contexts, professional, family, etc. And within the groups, whether it's a group or a family we're working with, they too may communicate differently to different people. You have an adolescent that's coming in with their parents, and we're looking at a much, with the Latinx family, we're looking at a much lower context. They're looking at body language, they're looking at the, crossed arms, and, you don't do that to me. But in another context, if I'm working with that adolescent in a group environment with other peers, they might not be, they might be much higher context. So as the treatment provider, I have to be able to recognize the difference, and even that one client of how they may adapt differently depending on, even their immediate context and how they're communicating.
Thank you. We have a lot of people that informed that it was a great presentation, that they enjoy it. Muchas gracias. Another comment is, thank you for the cultural context. As a risk safety profession who teaches well-being for high-risk industry like construction, your approach is very important. I learned a lot and wish to thank you for the excellent learning opportunities.
Thank you.
Can you pass Dr. Evans, can you pass to the next slide? Where is your contact information there?
There we go.
So there's a question if you can share your contact information, maybe email.
Yep.
Um,
So I can read it here. So if you'd like to contact me, my email is Dr. Michelle Evans 115@gmail.com. So again, Dr. Michelle, MICHELLEEVANS 115@gmail.com.
Okay, we have another question is, I am here in Florida and I have to be very careful because we have a huge Cuban population in the South, accessible Puerto Rican population in Central Florida, and a growing Mexican migrant, and now permanent population in North Florida. I get so concerned to step on toes instead of trying to understand carefully. I am correct for being this careful with our Latin groups?
I think because I totally empathize, because often, even though, I speak on this and I've done so much research on it, when I work with especially someone where I'm like, okay, this is not, such as African American populations, which is not a population I work with a lot, and so, but, or other populations, I totally empathize, because that is a goal. Our goal is, it's, in approaching it, I don't want to be offensive, but I want to be open. And so I think where we go back to is that not knowing perspective, where it's the, hey, what I usually tell my clients, and this is my quote: you are the world galactic expert of you. You know what you do, you know what your families do. I have read a lot of books and worked with a lot of people, but I certainly don't know all about you. And so, and I try to set that foundation of, as we work together, please, I'd like to know what feels best for you, and so I try to invite that. I'm recommending, I'm recommending this, how so far we've I've given you a lot of psychoeducation today on, on thinking errors. Tell me about your thoughts on that. Does that, does that make sense? And I'm always listening for some of those things that we've talked about earlier today, of it just like, yeah, that doesn't make sense, or, well, this is what I think differently. But I think it's all based on that good assessment. And so that assessment of understanding, tell me what illness means to you. How do you view this? How do you view your problem? If even it's not illness, maybe it's just a problem. And so it's going back there and just really, acting like this is the first time I've ever worked with someone like you, which is true. Meaning I've never worked with you individually before. And so I'm just gonna, keep that not knowing stance, and offer up, hey, this is something I think, or I think it might help you. Can you tell me more? What are your thoughts on it? And of course, sometimes I have to say, this is my recommendation. Knowing you, after spending time with you, assessing you, this is my best recommendation. So I'm not saying don't, be firm in your recommendations based on your clinical knowledge, but also maintain that open kind of stance. But yeah, and I believe that people can feel that desire, to be open to that, because yes, we all are different at the end of the day. Yeah. So thank you for sharing that. I'm sure many people feel similarly.
Yes, that's true. Thank you very much. Remember that we have the link where you can fill out our GPRA, our evaluation, please. And also, if you want to follow us, there is information of our social media. And thank you to all the participants. Thank you for the presentation. And remember that also that you have the handouts or the slides that are in the handouts box. So thank you again and have a beautiful evening. Bye. Bye, Dr. Evan.